Right. Oh, well, thank you very much, Emma. No pressure at all. We now have an hour and a half to spread knowledge, power, and understanding. Shazadi, are you up to the challenge?
Definitely, definitely.
Definitely. Well, we'll try our best. Well, hi everyone. Welcome and thanks so much for signing up to this webinar. So for the next hour or so, we'll see how the time goes. You've got me and Dr. Shazadi Harper, who's a GP who specialises in menopause, and a safe space to discuss all things menopause. I have got my cup of tea. Have you got your cup of tea or whatever there, Shazadi? Yeah. Oh,
Okay.
yeah. No advertising. Thank
I
you
know,
very
I know.
much.
I've covered
I
it.
saw that.
I've covered it. Yeah, there you go.
Are you a coffee girl?
Yeah.
Yeah, yeah. Well, I've got the tea. I've got the dog here just in case you can see how quickly. There she is. She's a menopausal lady, actually, in dog years. So the two of us, we're sitting here. We're menopausal ladies. So I hope if you're listening in or you're watching in today, you've got somewhere comfy to settle down and listen into this. The session will be recorded, and I think that's there on the chat. And so it will be available afterwards if you want to catch up with it. Or as Emma says, tell your friends, tell your colleagues. Thank you. Debbie says I've got a cute dog. It started off in a nice way, hasn't it? I mean, I hate to go on about lockdown. I know that that's not a great topic, but the one thing it did do was introduce us to Zoom. And a lot of us are fed up with Zoom because we'd much rather deal with people face to face, and I get that. But Shazadi and I did a session a while back, and actually we discovered, didn't we, Shazadi, that this is actually the perfect format for this kind of conversation, because people can, listen in, ask questions, get involved, and I'm going to explain how we do it there. And whatever the question, however basic, really it doesn't matter. I mean, I sit on Loose Women every week. I am used to daft questions. And Shazadi, you're 100% unshockable, aren't you?
100%. Yeah. I might not have said that a year or two ago, but definitely now, throughout sort of the pandemic and lockdown, I've learned a lot, heard a lot. And yes, I mean, this is a great format because we've got such a big reach as well. Whereas, before on the face-to-face side of things, maybe not everybody could have made it.
Well, yeah, and it is a really critical thing about where we are in our menopause discussions is that we start to join the dots and talk to each other. And we're really starting to do that now. I mean, I think certainly when women were coming into the menopause, and I did this, and I don't know if you did, Shazadi, you would start to speak to friends and people close to you, and you say, is this happening to you? I mean, is that, and so you would have mini networks. But to really change the conversation to the way that we want to, we're going to have to expand that and have a much bigger, more public conversation. And I don't know what you feel, Shazadi, but this week with National Menopause Day on Monday, it's just gone to another level, don't you think?
It's amazing, actually. I think it's amazing, the awareness, when people raising awareness. And in some ways, I think we have got the pandemic, COVID, a little bit to thank for it, to bringing people together on social media, bringing people together on Zoom, and getting us all talking. So, and this week has been crazy.
Emma has shared with me some of the information that you've all, the feedback that you've all given when she sent out the invitation. So as we go through this, I'm going to try and make sure that we cover everything that has come in already. She's always also forwarded me some questions that everyone has forwarded in. But the great thing about this format is that we can take questions live. And do excuse me if my eyes are shooting all over the place, because I'm looking at the screen and I'm also looking at the chat box there. And now, listen, I'm a bit nervous, but I don't think I should probably give people's names. So please don't think I'm trying to be impersonal here, but I'm going to try and keep an eye on the questions that are coming in. You're all probably dead familiar with this format because we have been doing it for such a long time. But if you look at the bottom of your screen, you will see the Q&A box, everyone. If you would like to ask a specific question, and I see we've already got some in, pop them in there. And if you would just like to give us feedback, just keep the chat going. I can see people talking about confidence levels. So I am writing that down. And I can also see a very dedicated person. I will say it's Andrea Lowe. I'm sure she won't mind me saying. She says, I'm looking away at times because I'm sitting at my work desk. The NHS never stops. We know this, Andrea. We know that. So if you want to ask a question, then put it in the Q&A. If you would like just to give feedback, particularly in terms of what kind of support would be helpful to you in your workplace, keep it coming on the chat box, and I will try and keep across both of them. Don't worry if you don't get the right format. I will try and keep it across both of them. I can see lots of questions coming in. We're going to be really busy. Shazadi, maybe we should just fill people in quickly a bit about you and why you developed this interest in menopause as a specialism.
So firstly, I'd like to say I am a proper doctor. I was working in the NHS for 25 years. I've been a GP in Oxford, and literally sort of in the last 5 years thought, you know, this is what I want to do. You know, I want to find my niche, women's health, partly because I felt that women's health in midlife wasn't given that attention. It felt a bit neglected. And I was seeing so many women who were being passed from pillar to post, from one specialist to another, and no one was joining the dots. And I really wanted to be that person to join the dots. My mother also has dementia. And so I was aware that, or I thought that, you know, her dementia got worse around her menopause. Yes, she's got lots of other factors, but I definitely felt hormones were one. And so a bit unlike UK in some ways, I was a real early kind of sort of advocator for sort of taking a proactive approach, you know, going on to HRT because of my brain, my mind. And also I have 5 younger sisters, so I was always going to go through it. You know, I just remember when it was my periods, having to hide my sanitary towel to get to the bathroom because my sisters were going to be, you know, sort of teasing me about it. And I have a daughter, you know, and I thought, you know, I want her to grow up in a much more sort of open environment, and for her to know that this is a normal part of the process of being a woman. So yeah.
See, I mean, I applaud you for that, because I mean, I have now come out and said that I was very much a menopause denier. You know, if I'm really honest, I didn't want to recognize that it was happening. I probably was guilty of all the kind of negative connotations attached to it, that I wanted to distance myself from the menopause, which when I look back now, I don't know where my head was. I mean, how was I going to deny a natural biological event? But I just didn't. And so symptoms came up with me. I didn't have any particularly dramatic symptoms. So when I look back, more than I thought I had night sweats, but I just thought, oh, well, I'll stick my leg out the bed, you know. Again, I didn't think menopause. And now I think, what the hell was I thinking? But the main thing for me was anxiety. And I was very much aware of being more anxious, more jittery. You know, the kids, I could see them getting fed up with me because I was just a real kind of worrywart. And I just felt a bit low all the time. And I can see lots of people coming in with those kind of emotional swings. But again, like a lot of people, I mean, my parents were elderly and getting to the point that they were in need of care. So that was a huge worry for me. My kids were teenagers, so they were up to all sorts, as teenagers are. You're trying to do a full-time job. I thought, this is life. This is middle-aged life. And I think a lot of women are in that position, aren't they?
I think a lot of women just put it down to life. You know, in the last year, they've also put it down to COVID, you know, and that's why they think they're feeling stressed, they're anxious. You know, they're juggling so many different things, and they're just thinking it's normal sort of aging process. There's an element of acceptance. And, you know, although I've said all of the sort of things why I did this, there was also a selfish reason within me as well. You know, I'd also seen women sort of fade away, having gone through the menopause transition, or they suddenly seemed older, you know, they suddenly gained a lot of weight, and it almost like they had aged overnight. And from my selfish point of view, I was single and still wanting to mingle. And I thought, you know, I wanted to look good, and I wasn't prepared to fade away personally. And I felt that this could be a real great time in my life. I saw women lose their sparkle, and that was very sort of typical of so many women. But, you know, I think there are more women in some ways like yourself, Kay, who just think it can't be happening to me, or that the image of a menopausal woman was somebody much older, looking very different from yourself. And so you just thought, well, it's far off in the future. I'm juggling, I'm being a carer for my parents, you know, children, work, relationship. It's just life.
Yeah, and it's actually, we were talking to Emma before, weren't we? I wonder now, if we look back as younger women, did we in some way unconsciously contribute to that negative image of menopausal women because we wanted to distance ourselves from it, and we didn't want to try and understand what was happening, because we just wanted to put clear blue water between us and those older sweaty women.
Well, I think the narrative has very much been sort of, hot flushes and moody women, hot flushes and moody women. We now know there's so many more symptoms. We also now know that, when we talk about menopause, there's actually much more going on. There are different stages going on, and that the symptoms can start earlier, and that there are many more symptoms. There's not just 2 or 3, there's 34 plus symptoms, and one of the ones you just said, jittery legs, restless legs. Who'd have put that down to, being a menopausal symptom? So I think, that's why it's great that we're talking about it more, normalizing it and getting it out there.
Well, listen, I can see the questions are coming in really, really thick and fast, and I want to get through as many as I can. But just before I do that, I'm going to ask you, and I apologize if this seems patronizing, everyone, for me to ask Shazadi to explain what the menopause is, but I think it probably is worthwhile just for you to give us, from a medical perspective, what is happening in our bodies at the menopause? When can we expect it to start? How long can we expect it to last? And as you said, some of the symptoms, because it's so much more than hot flushes.
Yeah, so I'll just be sort of brief-ish about it. So there are physiological changes going on in our body. Our ovaries produce our female sex hormones, and what starts to happen in that menopause transitional period is that those hormones start to decline, and so our periods become erratic or heavy or light, and so menopause is defined as when your periods stop. It's your last menstrual period, and you only make that definition a year late, diagnosis a year after you've not had a period. So it's what we call a retrospective diagnosis. And for most women, their last period is around the age of 51. And that is an average. Women of ethnic minority or lower socioeconomic groups or single women do tend to go through it a little bit earlier. And that time leading up to menopause is called perimenopause. And what's going on then is our ovaries are still producing hormones, but it's particularly our estrogen hormone is fluctuating and it's declining at the same time. And our hormone progesterone is declining at the same time. And progesterone hormone is often called our karma, and it's the first hormone that starts to decline in early perimenopause. And that's why women might experience symptoms like insomnia, anxiety, feeling overwhelmed, feeling that they're not coping as well. But also the combination of sort of the declining estrogen hormone means that they may feel low in mood. That's what gives rise to those vasomotor symptoms, night sweats, hot flushes, vaginal dryness. Are you getting up in the night to go for a pee, which is also due to your pelvic floor weakening, bladder leaks when you jump up and down. But things like the lesser known symptoms like restless leg syndrome, tinnitus, vertigo, itchy skin, dry eye, these are sort of some of the symptoms that we know less of. And one of the big symptoms, I would say, particularly in the workplace, that women get affected by is brain fog.
Yeah.
Sort of that hazy brain, forgetfulness, forgotten what they've put down. Have they done this? They end up repeatedly checking something midway through a sentence or a presentation. They forget where they were going, even to the point that, they may meet somebody that they know very well, but they can't remember their name straight away, and they're fishing around in that brain. And that all leads up to that loss of confidence, that loss of belief in yourself. And, many women, we talk about 1 in 4 women consider leaving their job or going part-time because they start to doubt themselves. So those are the sort of different stages: perimenopause, menopause, and then a year after your period. That time beyond is called postmenopause.
And in terms of which symptoms that you may or may not experience, is that just pot luck? I mean...
So one of the things to also think about is your life. And I think symptoms impact women in different ways. Many women may get similar symptoms, but if you are but it's how it's impacting in your lifestyle, in your work, if you're rushing around dropping children off, if you're being a carer. So stress has a big part to play in how maybe you're affected by your symptoms. But yes, on the whole, it can be potluck. You know, those women who maybe have had PMT, PMS in the past, often experience slightly worse symptoms. And, you know, that is a good way for some women to describe perimenopause, is that it feels like permanent PMT. And I forgot rage in all of that: rage, irritability, hypersensitivity, you know, all those symptoms as well. So it very much is dependent on each woman, you know, her own stresses in life, you know, what's going on, what are the demands on her. But it is a bit of potluck. I mean, the stats say that, you know, approximately 1 in 4 women sail through it. I mean, I would say they sail through it, but that doesn't mean to say they don't have any symptoms. I think, you know, they've got a different lifestyle, maybe a nap in the middle of the day, you know, being able to sort of have a lie-in, those kind of things. So the impact of it on yourself, it very much depends on, you know, all the demands made on you. And as women, we know in midlife, so many demands are made on us nowadays, you know, very much, you know, compared to maybe our mother's generation or our grandmother's generation. I think we as women are supposed to do it all.
Yeah, yeah. Well, I mean, just when I was in my 20s, I only looked after myself. That was it. You know, I mean, you went to work, you went out, you socialized, you got your heart broken, whatever. But essentially, you know, for me anyway, because I didn't have children early, I suppose it was quite a selfish lifestyle. I mean, cut forward 30 years, as I say, when you've got elderly mom and dad, 2 kids, take the dog out, a job, etc. And then you pile that on top. It's a lot. Now I'm just looking, lots of people obviously talking about HRT, and we are going to get into HRT. There's been an awful lot of chat about HRT in recent times. The whole debate around HRT has really moved significantly. But just picking up on people's emotional feelings. And again, I don't want to use names. They're all on the chat anyway. I don't know whether I should or not, but I'm going to stay away from it just in case. This is someone saying, because my symptoms weren't physical, I thought I had just flown through the menopause easily. It was only after 7 years after that I realized my symptoms were mental health. Well, I would go check to that. Yeah. I would say that I went through physically very well, but in retrospect, it was anxiety. People talking about different aspects of their confidence, brain fog, memory, and also SSRI meds. Now, these are anti-anxiety medication, yeah?
Yeah, the SSRI, selective serotonin reuptake inhibitors, and they're used for anxiety and for depression, and they help to maintain or prevent the breakdown of our happy neurochemical serotonin, so keeping the levels sort of high in the brain. And funnily enough, that is similar, or estrogen works in a very similar way as well to that. So estrogen helps to maintain our happy neurochemicals in our brain. It also helps to maintain the synapses, the connections between the nerves, so the communications between our nerves. And so when estrogen levels go down, we feel flat in mood, and also it's a bit like our Wi-Fi's gone down because the connections aren't there. Hence that sort of forgetfulness, or, you know, not remembering things, or not feeling as sharp or as focused. So we do know that the female brain does go through physical changes because of estrogen loss or estrogen decline in perimenopause and menopause.
Somebody's put in a question, which I think is a great one, or about themselves, saying, I'm not able to separate my symptoms, mental health or menopause. Should we be separating them?
No, I mean, the thing to remember is you can be depressed, anxious, you know, alongside your menopause and perimenopause, you know, but the thing is, you know, I would say not to separate them initially. You know, the thing is to address them. And if you feel they're not improving, then you sort of tackle them in individual ways. So, you know, I think it may well be that they are contributing to each other. And there has to be a bit of unraveling going on. It's not usually sort of like a one consultation fix. It may take a little bit of time to work out what's menopause and what might be life anxiety, and maybe, you know, sort of additional mental health issues. Yes.
Another comment there that I think is a really interesting one. Someone saying, I've been on antidepressants for years, but I've been trying all year to get HRT with no luck. No one is listening to me. Perhaps anecdotally, but it feels that GPs, and we're not GP bashing, you're a GP yourself, Shazadi, that they're much more willing to hand out antidepressant slash anxiety medication than they are HRT. Is that a fair comment?
I think it is a fair comment, because I think, you know, I said at the beginning that, you know, our image of menopause was sort of sweaty, hot, moody women. And I think it's the same for probably GPs have that image. You know, they haven't had that much training in menopause, you know. I was explaining to you before, you know, as a GP trainee, during my GP training, we have a day a week of education, and I can't remember having any menopause education during that sort of day. And so I think they've probably got the same kind of view as maybe the general public has. And so when somebody presents with no physical symptoms and more of the mental health symptoms, which can occur in early perimenopause more so than the physical, then yes, they may go down the route of offering you antidepressants or anti-anxiety medication, when actually, you know, something like medical hormone treatment, HRT, might be more beneficial. And that's actually what the NICE guidelines also say, that you know, HRT should be prescribed for what we call menopausal mood disorder first line, rather than SSRIs, unless a woman can't take it. Yeah.
Right. I am going to get into HRT full blown. I promise you, folks. I know there's lots of people want to, but just in terms of some of the other symptoms, somebody saying they've experienced weight gain, somebody else saying suffering with horrendous skin dryness. Are those symptoms that you see often, and is there anything that you can suggest that might help?
So again,
hair loss is the other one. Sorry, Shazadi, I'm going to put all three in there.
Hearing loss,
hair loss, dryness, skin dryness, and of course we have to be candid here, that can be vaginal as well as in other parts of your body, and weight gain.
Yeah, so I'll tackle skin dryness first, because estrogen is the main hormone at play here, and estrogen helps us sort of retain moisture in our skin, and also helps with our sort of elasticity, the collagen within our skin. So drop in estrogen, drop in that sort of plumpness of our skin, you know, it becomes more dry, it becomes thin, more crepey. So, you know, even women who've got eczema and psoriasis may feel that their eczema and psoriasis has got worse. And when we talk about that dryness, like you said, it's not just body, you know, it's also vaginal dryness. You might feel that your hair's become dry and brittle, brittle nails, and dry eyes. So yes, it does impact. It is a symptom. The hearing loss, I mean, hearing loss is part of aging. You know, it does happen as part.
Sorry, it was hair loss, ironically.
Was that your accent then? Sorry.
It was, but as it happens, I've got hearing loss. So if you'd like to tell us about it, I'll be absolutely thrilled.
Yeah. So hair loss, yes. Hair loss is, you know, the funny thing is, or not funny, but what I mean is, many women put up with symptoms like hot flushes, and you know, for a number of sort of months or even years. When their hair starts to fall, they're in that clinic straight away. They're there seeing me, and hair loss can be for a few reasons around this time. Stress is a big reason, you know, so you know, any stressful event, illness, you know, a lot of people have talked about how COVID has caused them hair loss as well. So, you know, illness, stressful events cause hair loss. But also, you know, when you're going through your perimenopause, heavy periods might be one of the things that's going on. So heavy periods might mean that you are iron deficient, and iron deficiency anemia can cause hair loss. Some women develop an underactive thyroid. That can also cause hair loss as well. And the hormonal changes that are going on. So estrogen levels declining also means that your hair is falling out, you know, the follicles on your scalp flatten, hair becomes finer, it becomes thinner. You know, women talk about their parting getting wider, the ponytail getting smaller. So yeah, hair loss is a real feature around this time for many women. And did you say, what else did you say? I forgot.
Weight gain.
Oh, weight gain. How can I forget that one? So weight gain, it's a tricky one, this one, because we are leading much more sedentary lives these days, and women much more so than men. And in our 40s, our metabolic rate does start to slow down. So if we carried on doing exactly what we were doing in our 30s and eating exactly what we were doing in our 30s, because of our metabolic rate changing, our body would start to gain about 0.5 kilo per year. The other thing that's going on is that our hormone testosterone, which we as women have which we as women have, has halved from our 20s into our 40s. And testosterone helps with metabolism, but it also helps with muscle mass. So you might have noticed your body composition changing. So it's more fatty, less toned, and muscle burns off calories. So, you know, the other thing is we have less muscle going on. Again, going back to the fact that we might not be sleeping so well. So when we don't sleep so well, the next day our sort of hunger hormone, ghrelin, is elevated, and our feeling full hormone, leptin, is not working as well. So it's almost like a dog chasing its tail. We're reaching out for carbs, coffee, sugars to give us that sort of energy, you know, and fatigue and lack of energy is a big symptom around this time. So it's almost like we're trying to give ourselves a bit of a boost. So we end up eating a bit more, and we're not exercising as much as we do. So there's a lot going on here. And weight gain, the other thing is that women say, you know, I've cut down on what I'm eating, I'm exercising more, but it's not converting like it used to in my 20s and 30s. And that's because hormonal, the changes in estrogen and progesterone levels has a domino effect on other hormones like insulin, and cortisol is our stress hormone. So cortisol levels are up, it means it diverts blood flow from our gut, we end up storing fat. Insulin's not working so well, so instead of using up food that we're eating as energy, we're ending up storing it as fat as well. So there are a few things going on around that time that we need to address.
I'm just aware we're painting a bit of a bleak picture at the moment, but having said that, there's no point in running away from things. And actually, I'm looking at the chat, and it's lovely to see people sharing their experiences on the chat, which I think is one of the benefits, a sort of sidebar that is going on here. And there's a couple of comments that, you know, remind me of the real world sort of implications of all of this. Somebody saying, I feel I'm not able to do my job properly, so I've reduced my hours to see if that helps. Now, that's a double-edged sword, isn't it? Because yes, I mean, we're not going to tell anyone what they should and shouldn't do with their working life, but on the one hand you think, well, maybe that's good, you take that time for yourself, and so that you're not overstressed and you are able to give yourself a little bit care. But having said that, if more women are doing that, or doing that on scale, then you're taking out an incredible amount of expertise and experience from the workplace at a time that the economy can't afford it. But also for women, if you've spent 25 years building your career, you've got a lot to give, and that you're feeling you're forced to come back from that, well, you know, that's a very unhappy decision, really, isn't it? That's not an elective decision. That's a kind of, well, I don't see any option decision.
Yeah, it's not a choice, you know, and women are reaching, you know, sort of the pinnacle of their careers at this point. Many women are, you know, they've worked really hard for it, and then, you know, they start to sort of feel that loss of confidence, that doubt, and, you know, stepping back into a part-time role or even changing roles when it's not really an active choice, but because you feel you have to. It has a negative effect on your mental well-being, but also on your financial well-being as well. So, you know, it's important to understand, not only does it financially affect you as a woman, but yes, like you said, Kay, you know, the economy, and you know, then there's that brain drain from sort of workplaces.
Yeah, well, we will talk a little bit later about workplaces and what they can do to support people. And I mean, I actually haven't got through all the chat yet, folks, and I will obviously with interest later, and I'll try and get through as fast as I can. But Emma did say to us that she would love to have your thoughts in terms of what kind of measures within the workplace would make you feel more comfortable, because it's really important that this starts off a conversation. It's not a one-off tick box webinar. It's the start of a process rather than the beginning and the end. that's a workplace. Also talking about people's personal lives and intimate lives, I guess. A couple of people saying that their partners, their husbands, have seen a complete personality change. That can obviously put an incredible pressure on relationships, particularly if libido also goes down as well.
It does, and even in long-term relationships, the fact that, women are tired, that loss of libido, that change, like you said, in personality, doesn't just affect you as a woman, but has that ripple effect on your family members and your relationship. And, loss of libido is a big symptom. Often women say it's just almost like it just switched off overnight. And the other thing is, the physical changes, like the vaginal changes, vaginal atrophy, dryness, can make sex extremely uncomfortable and painful. And trying to explain that to your partner can be quite hard, to sort of say, well, this is what's going on, this is what's going on in my head. But, and one of the things, though, to understand is, women do lose what we call that initiative drive, which is that sort of they initiate sex. But women do retain that that reactive drive, so that their body does respond. So I think sometimes women get that anxiety that their body's not going to respond, and that fear, and so they're avoiding sex because of that. But on the whole, it does. Your body does respond. You do get a reactive. You still have that reactive drive. And I think it's really about educating your partners as well. It's all about communication, and getting them involved in your journey effectively, and maybe even going to seek help together. When you go and see your doctor. I mean, I actually do see many couples together, because the man can also feel rejected. He's feeling, well, she doesn't want me, or what's wrong with me, and men do have, I would say, more fragile egos than women, and they do have a funny way of turning it around and making it all about them. But there is that element that they do feel a bit like that, that they can feel rejected, and then it becomes this sort of elephant in the room scenario that you're just avoiding each other.
Yeah, well, I mean, I guess also if the public conversation about menopause starts to reach into mainstream areas, then that is also going to help that, because then you're perhaps not starting from ground zero with your partner. That they will have heard these conversations. I mean, in this week, they will have heard conversations about the menopause. I mean, I remember asking my partner about the menopause because I co-authored a book about it, and he's a 58-year-old man. He didn't. I said, do you know what the menopause is? And embarrassing silence for about 2 minutes, and he just didn't. And the thing is, I couldn't really get onto him because I had been ignoring it as well. I thought, oh my God, what a useless pair we are,
Well, I think times are moving. My sister went to visit my brother, and my nephew opened the door, and she was feeling a bit hot, panicky, and my nephew's 12 years old, and he sat her down and he said, "Auntie, do you want a glass of water?" And she went, "Yes." And he said to her, "Is it menopause?"
Oh,
and
wow.
she went, "Yes." And that's because he likes to follow me a bit on Instagram. He hears me talking about it, and hopefully that's going to be the new generation of men, coming up, so that it will just be so normal just to say, "Is it menopause?" Gets a glass of water. He then got a pillow and fanned her a bit.
Oh my God.
And then went off and played on his computer game or whatever it was. It was just there was just that normal flow. There was no sort of joking, awkwardness, nothing like that. And I think that that's where we want, sort of men and women to be, because I think even younger women don't know much about it as well.
Yeah, your 12-year-old nephew is now menopause goals. I mean, how incredible is that?
I know, he's lovely. He's absolutely lovely.
Again, I'm sort of looking here. People want to talk about HRT, but I think we should put that in the context of, okay, we have discussed a lot of the symptoms that women can encounter, a lot of the challenges that this period of life can present. So obviously we want to be a bit more positive and say, right, okay, here are some good responses to that hopefully are going to make life a little bit more easy. So we'll wrap HRT up in that. We also want to talk about when you know it is time to go and speak to someone about help. Who do you speak to? What do you say? How do you start that conversation? And I see a lot of people also talking about being on the pill and contraception and what the crossover is, because of course perimenopause, this time, and you've written a book about this, haven't you, Shazadi? That is kind of the twilight zone before the menopause comes. A lot of women will be on contraception and they'll be thinking, okay, well, how do I make that step change in my life? So I'm noting these things down, folks. I know we need to get onto them. Shall we talk about how we manage our menopause then? We know that it poses lots of challenges potentially. How do we manage it? And HRT is clearly one of those ways that women are very aware of now. And I'll hand that to you, Shazadi, because I know you're not somebody who goes HRT first, but it is very much within your kind of suite of potential managements.
Yeah, I mean, I think this is a really good time for women to sort of take stock. You know, often we've not prioritized ourselves. And I often say, look, now's the time to make yourself a priority. And, you know, as GPs, you know, throughout, maybe every time you go and see your GP, your GP talks about your lifestyle, stopping smoking, you know, not drinking alcohol or reducing, moderating it, you know, all of those things that you think, oh, I'll put it off, I'll put it off. Now's the time not to put it off, because things like, you know, sort of drinking alcohol can exacerbate your hot flushes. And we know that many women sometimes turn to alcohol as a bit of a soother, as a bit of a calmer, to help them sleep or to help reduce their anxiety, whereas actually, you know, it can have the converse effects. You know, things like smoking, stop smoking, because that also thins your skin and causes wrinkles and dryness, you know, alongside the sort of the major issues like sort of heart disease and lung cancer. So, you know, stopping smoking is a big thing about this time, around this time. Having a Mediterranean diet, studies have shown, has been more beneficial to women compared to men in particular, you know, from the point of view of reducing your heart disease risk and helping with reducing your dementia risk. So there are those kind of lifestyle factors that have been spoken about, which maybe you haven't kind of put into play, you know, working out a nice way that you can do exercise, cardiovascular exercise, but also strength training. You know, I'm forever now telling everybody to weight train, which is something I'm taking on board because I love to eat. So the thing is, you know, I think if I have a few more muscles, then at least it'll burn off a few more calories. So that's my thing for wanting to do weight training. You know, it's all about food. But sometimes it can be hard for women to make those changes because they are so tired. And I think it is good that we're talking about HRT and we are putting it into a bit more context and balancing out the risks versus the benefits. But, you know, the other thing to understand is it doesn't always suit everybody. Not every woman can take it, and some women may be sensitive. But, you know, for those women who can't, for them not to feel that there's nothing out there for them, because there are other, you know, whether it's pharmacological treatment routes, but also things like cognitive behavioral therapy can help with hot flushes and anxiety. You know, acupuncture has shown to help with that. And there are sort of supplements and herbs that can potentially also help. But I think, yes, I think with HRT, the thing about it, there's been so many scare stories about the last sort of 20 years that women have been afraid to take it, to take it because of breast cancer. And I think I just want to talk a little bit about breast cancer in the sense of putting it into context, as in 1 in 7 or 1 in 7 of us. No, so we as women, we have a 1 in 7 risk of developing breast cancer over our lifetime, and our risk increases as we grow older. You know, so aging is something we can't do anything about, and the aging process increases our risks for everything. You know, heart disease, stroke, whatever you want to say. And we have much nicer preparations of HRT now, you know, ones that go through the skin, which are body identical. You know, so
what does that mean, body identical?
So you might have heard of bioidentical, but the reason why we say body identical, so body identical means the HRT is the same chemical structure as the natural the hormones that we have in our body. So our body produces 3 types of estrogen, which is 17-beta estradiol, estriol, and estrone. And most of the HRT preparations are 17-beta estradiol, because 90% of our body's estrogen is 17-beta estradiol. Natural micronized progesterone comes in the form of a capsule called utrogestan, and again, it's the same as the progesterone that our body would produce. So that is progesterone. When we say progestogens, those are what we call synthetics progesterones. So, but there's only utrogestan, which is a natural progesterone. Although now there is a new tablet that's come out, which is natural progesterone plus estrogen, which is an oral, which is a first actually that's come out only last month.
So risk-free?
I would say it's almost risk-free. You know, I think I don't want to put my neck on the line and say it's not risk-free, but I often do say that to women in the sense of, look, if you were to get breast cancer in the next 5 years, I would be saying to you, you were more like it was likely that you were going to get it anyway, and it's not this HRT. So, you know, it is minimal risk, but also the risk has to be put into context for each woman. You know, for example, if you are somebody who's obese or smokes or, you know, drinks a lot, you know, all of those things have to also be put into the equation. And a simple way, I think, sometimes of explaining it is, at the age of 50, a woman's risk, what we say baseline risk of developing breast cancer in the next 5 years, is 23 in 1,000 women will get breast cancer, okay, irrespective. A woman on HRT, and when I say HRT in this, I'm talking about all of the HRTs, not just the you know, the sort of the body identicals that we're talking about, then the risk becomes 23 plus 4, so 4 extra cases within that 5 years. A woman who drinks 2 glasses of wine every night, her risk is 23 plus 5, so 5 extra cases. And a woman who is obese, her risk is 23 plus 24, so 6 times more than HRT. So it's about putting the risks into perspective. It's about reducing what we would call those modifiable risk factors, the ones that you can do something about, you know, moderate your alcohol intake, increase your exercise, see if you can lose some weight. And when I say that, I don't say it lightly, because weight loss is not easy, and it's not just as simple as eating less and exercising more. There are many factors around it, but you know, those things also need to be addressed. And HRT can sometimes be that catalyst for change for many of these women, you know, who maybe are feeling flat, tired, have no energy, but want to make those changes and can't. So yes, it can be, and that catalyst for change, and help women with those symptoms of like brain fog, hot sweats, you know, their sleep. So make them much more functional and get their spark back, keep them in the workplaces for longer. So it helps with those symptoms in the here and now. But we also know that if you start HRT, what we call that window of opportunity, which is within 10 years of your menopause and under the age of 60, that it can help reduce your long-term risk of cardiovascular disease, your long-term risk of dementia, and also help reduce osteoporosis.
I mean, yeah, that's a side of HRT that is very rarely discussed. That, you know, I mean, we tend to talk about it in terms of a risk factor, don't we? Very rarely does anyone ever say, well, actually, there are potentially benefits. And actually, I'm going to throw in a question from somebody who says, due to a heart attack nearly 2 years ago, I am unable to have HRT. What would that link be? So I'm going to say, you know, one of the things is sometimes women think if they've got high blood pressure, they can't take HRT. For example, if your blood pressure is controlled, even if you're on medication, you can go on to HRT. Now, I can't sort of answer specifically for this lady why, because I need to know why she had a heart attack. Are there other factors at play here? But one of the things is women's risk of heart attacks
and heart disease increases after menopause because they lose some of the protective effect of estrogen. If you remember when I talked a bit about elasticity before, so your arteries become stiffer, so you lose some of that elasticity, and so it increases your blood pressure, and then it does increase, and also increases your lipids, your cholesterol, your triglycerides increase post-menopause, your insulin resistance increases, so at a higher risk of type 2 diabetes. And these are all because of the drop in your estrogen levels. So it does put you at a higher risk of cardiovascular disease post-menopause. So starting HRT potentially within that window of opportunity could help reduce your risks. So I can't answer specifically for that lady as in what's going on, but it could be something that helps to prevent your longer term or reduce your longer term risk of heart disease.
I mean, when you see patients, for which patients would you suggest HRT, and for which patients would you not suggest HRT?
I'll be honest with you, you know, by the time I see patients, many of them will have gone round the block, you know, having tried supplements. You know, many of them will have tried holistic measures like, you know, sort of acupuncture, yoga, exercise, sleep apps. You know, they'll have reduced their alcohol. You know, they will have tried many of these things. If they haven't, I'll say to them, you need to go and do that. And so by the time they come, or they can be quite desperate. You know, they could be, you know, one lady came and she said, you know, she's had a disciplinary at work and because of her brain fog, she can't remember. So sometimes they can be very desperate at this point. So just getting the ball rolling with a little, you know, with HRT, and I don't usually go in at, you know, super high doses or anything, but just getting that ball rolling can help them to get their identity back and their sense of being back, so that then they can be a bit more proactive in taking care of their health. So so yes, you know, I would say most women have tried, and if they haven't, then they are sort of sent away saying, look, try and see, make these changes. But often they can't because one, they may be absolutely exhausted, don't have the energy, or two, they've already done it. And for those women who can't take HRT, which might be women who carry the BRCA1 and BRCA2, you know, the
well, actually, sorry, Shazadi, but somebody has asked that specific question. I have the BRCA2 gene and have had breast cancer. Not sure if this would be more of an issue with HRT. All I know is I've been advised to avoid it.
Yeah, so that's a good question, because women with the BRCA gene, you know, if you've got one gene, you're at a 55% increase in developing breast cancer. If you've got both genes, you know, your risk increases by 80%. So for those women, sometimes we have to target specific symptoms. So for example, if your symptoms are hot flushes, night sweats, maybe anxiety, then yes, an SSRI might be more appropriate for you rather than HRT. And you know, for other women where maybe it's brain fog, you know, those kind of symptoms, we may have to look at sort of nutritional deficiency supplements that might be able to help. But you know, women with who've had breast cancer, for many of them, having local vaginal estrogen can still be safe for them. Okay. So whereas general HRT may not be, but you know, local vaginal estrogen can be safe for them, depending on which one that we prescribe.
And what would the benefits of that be? I mean, why?
So reducing vaginal dryness. You know, often women who've had breast cancer treatment, you know, feel that you know, they still want to have sex, they still want to have, you know, that intimacy, they still want to feel like a woman, and often they feel that I can't really ask for more because I should just be grateful that my breast cancer has been treated. So the local vaginal estrogen can very much help with your vaginal health, so help reduce your risks of reduce the number of maybe urinary tract infections, thrush. Also, it helps with a bit of your pelvic floor, strengthening that, and from the point of view of having a healthier sex life, you know, not to have painful sex because it reduces your vaginal atrophy.
Well, actually, the same person, and thanks very much for coming back on that, who asked that question, said that vaginal dryness is a massive issue. And again, we're back to taboo time, aren't we? I mean, it's a very difficult thing to discuss. And actually, I don't know if anyone saw the documentary that Davina McCall presented recently, which I think really did take the conversation up to another level. Maybe it was a bit too HRT heavy. I don't know, but I think it definitely took it to another level. But the fact that she was prepared to say that vaginal dryness was something that she had experienced, I mean, I thought, oh, respect, you know, because we need to be able to say that. I would find that difficult. I mean,
yeah. And I want to say, you know, we say the word vaginal atrophy, but the medical term is genitourinary syndrome of menopause. A bit of a mouthful, because but it's important because it's not just internally the vagina, but externally, you know, vulva, urethral atrophy, clitoral atrophy, and you know, so it's the changes happen externally as well as internally, and these things can affect your libido.
Yeah. And you know, the other thing that saddens me about this, so this is going on a slight tangent, but you know, obviously you need that area of the body to be healthy. And when you get into older age, I mean, when my mum was very elderly and very ill at the end, she had a lot of discomfort, clearly around her vagina and whatever. And you know, nobody ever thought that perhaps, you know, it would be due to dryness or atrophy or whatever. And when I think back now and think, my God, she must have been in such discomfort and pain, and it just wasn't a priority. And we didn't even sort of think, well, why is this? Why is she so uncomfortable? Why is she so, you know, itchy? Sorry, everyone, but I'm going on a tangent. But, you know,
no, I don't think you are. I don't
Yeah.
think you are going on a tangent in the sense of, I think almost at 40, you should have a little bit of a vaginal health check and discussion, and almost like be given some local estrogen, because, you know, it happens younger than you think. And I look back now and I can specifically remember a case in my general practice, you know, I think, you know, this was about 15 years ago, this woman who was 42, 43 kept coming back with his UTIs, and every time I dipsticked it, I thought, it was like, oh, but it's clear. I don't know why she keeps coming back. She'd had 4 children, and now I look back on it and I think that's what was going on. That's what was going on. You know, if I had given her some Vagifem or some, you know, some estrogen cream, you know, I wonder if that would have meant that, you know, it would have helped. Well, it would have helped her, but she wouldn't have had to keep coming back again and again. So yes.
Yeah, and we know that when women get into a geriatric phase, UTIs are just a constant source of problems, aren't they? Yeah. HRT, alternatives if you can't have it. I think we've covered that too. What I think is really interesting, the way that you put it, Shazadi, is that often it's an either or situation that is presented with HRT. You're either on HRT or you're not on HRT. And actually, I think the way you've described it is really useful to me, in that the lifestyle changes are good for everyone. You know, that there's no question over that. And for many people, that may help them manage their symptoms successfully, so that they don't necessarily feel that they want to go on and have anything else. But even if you do go on to HRT, those lifestyle changes are still key to feeling as good as you can be. Am I right in saying all that?
Yeah, it's not a magic wand. It's not a panacea. I often describe it there. You've got HRT and then you've got those bolt-ons. I don't, you know, so your bolt-ons are your lifestyle sort of changes that you sort of make alongside it. And for those women who can't take HRT, the other thing I want to say is, it doesn't mean to say you can't reduce your long-term health risks. You know, I'm saying, oh, HRT can help with your bone density, with your, you know, reducing your cardiovascular disease risk. But actually, you know, being really proactive, doing strength exercises, weight-bearing exercises, these help with your bones. You know, just generally sort of aerobic cardiovascular exercises that helps with improving the circulation to your brain. So, you know, from the point of view of dementia, you know, exercise is one of the #1 sort of preventers up there. And then that diet, that Mediterranean diet, to lower your cholesterol, you know, is great from the point of view of reducing your risks for dementia and heart disease. So it's not that only HRT will make those changes. You know, your lifestyle and making those changes will also reduce your risks as well.
Yeah, and I think as women, we really have to take that on board, because to a certain extent, and I mean, this is in no way a criticism of the medical profession, but in all areas of life, we're kind of used to, being told that we have to take responsibility of our health and keep your diet good and don't drink too much and don't smoke. And, you can think, yeah, yeah. But we have to take responsibility as individuals and say, well, actually, this is not just blah, blah, blah. This can make a qualitative difference to your life. And that's your choice, isn't it? Although
I think maybe COVID has shown that a little bit, that we have to take a bit more responsibility for our health as well. And also the NHS is under a lot of pressure and strain, and whatever we can do for ourselves will only help.
Yeah, well, that takes us fairly neatly on to what help is out there and how you approach your GP, etc. But just before we do, a couple of people have been mentioning the Lady Care Magnet. Now, I don't know what the Lady Care Magnet is. Somebody has said that they have used it very successfully. It's amazing. 3 weeks in, I've been able to get more than 3 hours sleep a night. I'm not allowed to have HRT. Are you familiar with this, Shazadi?
Yeah, I mean, I've heard of magnets and women saying that they help, sort of anecdotally. I don't know how strong the evidence is behind it, but I'm very much about, if it helps you, and it's not causing you any harm, then I would give it a go. But yeah, I mean, I can't really talk that much about the magnet. But funnily enough, I went to an event the other day and I got one in my goodie bag.
All right. Okay. All right.
So watch this space.
Okay. We look forward to you reporting back. I mean, I do have a friend who said she got attached to her shopping trolley because hers was, I don't know, she had to attach it to her knickers. So she had a really embarrassing encounter in Tesco. So let's talk about the conversation with the GP. But don't let me forget contraception, because I have got a lot of people talking about contraception, particularly perhaps in the perimenopausal stage.
It's important.
Note to self. Okay, so what kind of conversation do we have with our GP? When do we have that conversation? How do we have that conversation?
I mean, I think that if you're not feeling right, and you can't sort of almost like put your finger on it, and you feel that maybe your periods have started to change, you're not sleeping so well, then it's time to maybe go and have that conversation. Or you may have had, got cystitis a couple of times and you thought, well, why is that happening to me? Or you've jumped on the trampoline with your children and you think, oh my goodness, there's a bit of a wet patch there. And I think, what I would say to get the most out of your GP is, one, make a list. Okay. One of the things to help you make a list is, we can all go online almost, or is you can get a symptom checker. So if you go through a symptom checker, and I was going to say, and this is, I know it sort of feels a bit of a plug, but in the back of my book there is a symptom checker. And what I like about that, obviously I'm going to like about, because I created that symptom checker, is because it's slightly non-medical in the way that it asks questions like, are you feeling overwhelmed? Do you find that you're not coping so well? So maybe, some of the questions which maybe a doctor might not directly ask you. So if you can get a symptom questionnaire online, and tick it off, so you've got a bit of a preparation done there, make a list, ring your GP up, practice up, ask the receptionist who's the best person to go to for menopause, and then maybe somebody within your practice. Make the appointment with that person. Ask if you can make a double appointment, rather, because 10 minutes, you're going to speed through it like anything. And when I was in NHS general practice, I used to feel like I was on speed, the way I used to talk to my patients to try and get so much out of them. And then take somebody in with you. Maybe that person can take notes for you, or that person may be able to remember some things for you, because of brain fog. You may walk away not remembering all the details, and then you can't get through to your GP to sort of say to them, oh, what was it that you said? How was I meant to take it? So do that, a list, a questionnaire, go to the right doctor within your practice, and take a friend if you can. And if you don't have that person within your practice, then see if you can be referred to a menopause clinic, an NHS menopause clinic. There are some out there. There may be a bit of a wait, and then, but it probably will be worth the wait. And or if you can afford to, then to seek help privately. But I think you've got to do some preparation before you go walk into that general practice.
Someone's mentioning rightly, you can't get face-to-face with a doctor at the moment, and it depends. Obviously, different surgeries are operating different kind of systems, but a lot of people will have difficulty getting a face-to-face with a doctor, and certainly taking in a companion for the time being probably isn't an option.
Right thing. Yeah. Well, the British Menopause Society does say that GPs can do the consultation over the telephone and can prescribe over the telephone. So that was guidance that came out at the beginning of COVID last year, so that women didn't have to suffer with their menopausal symptoms through the pandemic. So you can still do it over the phone. You should be able to still do it over the phone.
I really think that advice you give, though, Shazadi, about writing a list and really doing a little bit of legwork before you go in is good. I mean, my own personal experience of going to see my GP, which I did, I don't know, about 3 years ago, whatever. Actually, I was a bit angry when I came out, though. I now, when I look back, think I can see what her point was, because I just went in and went, I don't know what's wrong with me. I just don't feel very good. I just don't feel myself. If I had a penny for every time I've heard somebody say, I just don't feel myself. And she was busy. I was being very non-specific. And she said, well, you can have HRT or antidepressants. What do you want?
Yeah.
And I was crushed. And so I just sort of toddled out of the surgery and didn't do anything about it. Had I done a bit of homework, and gone through something like the symptom checker and been able to say, look, I'm experiencing this, and this, and this, we'd probably have had a much more productive conversation. So I think, again, we have to take that on board, don't we?
We do. And because often if you do a brain dump, you may not have equated some of your symptoms to your perimenopause. And that's why a symptom checker can sometimes help you to focus and think, oh, actually, I have been experiencing this. I didn't put it down to that. Oh, yeah, I have been having really itchy skin. Oh, my goodness, it's because of the low estrogen. It's because of that. So it can help just to put a little bit of focus into what you're doing.
Yeah. It's funny, I was very proud of myself. I diagnosed one of my friends over dinner one night because she said to me, I've got a voracious appetite, I can't stop eating, and I'm just not sleeping. I said, menopause. And she went, what were you talking about? And I was right. I'd been doing my reading. But understandably, she hadn't put two and two together. They're just two kind of random kind of things. We have got a good bit of magnet chat going on here, just as a little bit of a sidebar here. Somebody picking up a fork from their in-laws dinner table with a magnet. Somebody else finds it very handy for finding their keys, which is probably excellent as well. Actually, Emma Marshall's been on the chat there. She's very kindly saying, feel free to mention your books. I think it is really worthwhile, actually, that you mention your book, Shazadi, because it's specifically about perimenopause, and I think that probably gets people started at the right stage.
Yeah, so it's written with my friend Emma, who's a nutritionist. So we wanted to look at the woman as a whole. Like we've said earlier, it's not all about HRT. So there's sort of there's a health section, a lifestyle section, and a nutrition section. So hoping that it will help women to become aware and take control of their symptoms, before they get to that sort of more darker place, and that they can take action sooner rather than later.
I think that is a great sentiment, actually, because with anything in life, if you feel out of control and you're on a bit of a runaway train, you don't know where it's going and you don't know who's directing it, that's always an uncomfortable situation in life, isn't it? Whereas if you feel you're being more proactive and that you're actually kind of driving the bus, then that tends to be a real good confidence boost from the very beginning, doesn't it? And certainly for people like me who chose to deny it and just kind of ignore what was actually obvious, then I was on the back foot. Whereas if women are aware of perimenopause, they're aware of the biological changes and they get in early, then you've got a much, much better chance of determining your own path, rather than getting to a stage where you're anxious, you don't want to go to that meeting, you're just feeling a bit shit, and you're going to have a chocolate bar. And at that point, you're on the losing side, aren't you?
Well, for me, it does come a bit from the heart, because I've always had PMS, and I've always felt a bit out of control, like going from 0 to 100, and that rage and that red mist coming out. So you know, I know what it feels like, and I usually don't present myself to the rest of the world in that week. So don't worry, nobody other than my daughter gets to see that. But it's that horrible feeling of feeling out of control. And I know what it feels like. So I really wanted to help other women not have to feel like that. I mean, I still get it occasionally, but I'm just saying not as frequently. So it's all about sort of managing that. And on that point, I also want to say that if you go onto HRT, or you know, to sort of do take other forms of action, there has to be a level of acceptance. You're not going to be like you were in your 20s and your early 30s. You know, your memory's suddenly not going to become Mensa standard or something like that. You know, I usually say to my patients, if I can help you get to about sort of 70 to 80%, you know, then that is good. And then and you know, there has to be a management. You know, I do have to manage the expectations as well. So, and I think most women say, I'll be very happy with that. You know, I'll be very happy with that.
Yeah. I want to talk, I'm mindful of the time, because I know people have got stuff to do, but I want to talk about contraception a little bit. I've got a long comment here though, which takes in a few things. Somebody saying they've taken Badgifem prescribed by a menopause doctor, and it really does work. So there you go, that's a good thing. Because somebody else is asking about a lubricant for vaginal dryness. Regular ones don't work for me. I'm on HRT, progesterone capsules every day. I was prescribed a localized cream that was used for a while, but it caused discharge, so I stopped using it.
So sometimes some women may get irritated to one or the other, and some women do to the other, not to, you know. So it can be, you might have to try one or two to get the one that is for you. And I think, yeah, contraception is. I'm keen to talk about contraception.
Right. Okay. Right. Sorry. I broke into my own thoughts there, which was quite incredible. This one here about taking Badgifem prescribed by a menopause doctor. My mum was prescribed this by a wonderful bladder and bowel specialist at the age of 84.
Yeah.
And lots of issues following a stroke and cognitive impairment, which was exactly the same as my mum was at. When the nurse explained what the treatment does, I realised that I was suffering the same symptoms at 52. It's taken me a long while to get medication, but it's been a couple of months and it's working really well. We're used to feeling that the effects of aging are inevitable, but we don't have to put up with it. I like that comment, because it just sees our health on a continuum. And I think one of the issues is we talk very much about, you know, sort of earlier periods, starting pregnancy. We've got so good about talking about that stage. Still, with other conditions like endometriosis and stuff, we're not. Menopause has been in the shadows. It's coming into the light. But we've got to see this as a continuum of women's health throughout their lives, haven't we?
We do. And I saw in the chat people talking about sort of B12 and things. And you know, when we're talking about women's health, these nutrients, you know, also need to be addressed. You know, vitamin D, iron, B12, you know, don't just let them tip into the normal range. You know, to be optimal, they do need to be more at the higher end. And, you know, we talked about hair earlier on. So B12 can help with mood. It can help also from the point of view of, you know, sort of energy as well. So, you know, make sure you are taking vitamin D. You know, brown and black people need to have more vitamin D than Caucasians. Make sure you know, if you are vegetarian, you are taking a B12 supplement, an iron supplement. All of these things are things that you can do to help yourself at this point.
Good. Right. Okay. Contraception. Finally. Sorry, that was me disrupting everybody there. When you're in the perimenopause stage, should you still be taking contraception when your periods stop? Do you stop taking contraception?
Yeah. So you can still get pregnant when you are in perimenopause, although you might not have a period every month, and it may be that you're not ovulating every month. But 1 in 100 women do get pregnant at the age of 50. 50, at the age of 50. So contraception is necessary. One of the things that can be almost like a 3-in-1 for women during those perimenopausal years is the Mirena coil. So the Mirena coil has some levonorgestrel hormone, and so it can act as your contraceptive. But also lots of women experience heavy menstrual bleeding. So what it can also do is reduce your flow. And then if you do decide to go onto HRT, because, you know, for those women who have a womb, they need to have estrogen and progesterone, it can be the progestogen component of your HRT. So it's a 3-in-1. If you're not on HRT, you're not on the pill, and, you know, if your periods stop under the age of 40, you have to wait 2 years, under the age of 50, sorry. So I'll recap. So if your periods stop under the age of 50, you have to wait 2 years before you stop your contraception. So you have to have 2 years without a period before you stop contraception, if you're under the age of 50. If you're over the age of 50, then, and your periods stop, you have to wait 1 year before you stop your contraception. So, you know, you have to have 1 year of no periods. So you're into post-menopause, and then you can stop your contraception. But under 50, you have to wait 2 years before you stop.
Okay. Just one thing I wanted to ask, and I'm scanning back to see if I can find the question, but from memory, I think it was somebody who had been on the combined pill.
Yes.
And was concerned about HRT as a result of that. I will scan it, but can you understand why that would be?
Yeah, so women can stay on the combined pill up until the age of 50 if they are fit, well, and a non-smoker. Many GPs try and change women over to the mini pill or the progesterone only pill in their 40s, just from a sort of a safety profile perspective. Now, so the combined pill, because it has a synthetic estrogen and a synthetic progestogen in it, may mask some of your symptoms of menopause because it's giving you add back hormone. HRT is not the same as the combined pill. It is not in the same high doses as what's in the combined pill. So sometimes women say, look, I didn't suit the pill, will I still suit HRT? Potentially yes, because it's a lower dose, it's body identical. And so it doesn't mean to say if you've not suited the pill that you won't suit this. So, so it may mask some of the symptoms. So when you come off the combined pill, you may suddenly get a lot of symptoms which, you know, your contraceptive might have masked. And then, but yes, you can go on to HRT.
Okay, all right, good. I think we're probably going to have to start to wind up. We do have just a couple of questions, a little poll question for you, a couple that I'd be really grateful if you would just click on. Let me get the first one for you. I mean, all of this is just really vital feedback, and I'm loving this conversation that's going on in the chat. It's brilliant. But can we ask you, everyone, how comfortable you would feel talking to your line manager about any menopause symptoms that you have? It's just a simple yes or no. Would you feel comfortable speaking with your line manager about your menopause symptoms? It would be really good if you would respond to that. Just gives Emma and her team an idea of how people are feeling in terms of being in the workplace. So that would be good. We're also getting some really good suggestions coming up on the chat about what might make things better within the workplace for you. And so please do continue to throw those in. Shazadi mentioned her book. Don't worry, this is not going to become a plugging zone, but we do have a giveaway because it is a World Menopause Day, and we're giving away copies of Still Hot, which is the book that I did, and I'm suddenly looking around this room to see if I can find one somewhere. Isn't that dreadful? I should have had that.
I've got yours here.
Oh, well done, thanks, Shazadi. That shows you how rubbish I am. I've got somebody else to get my book. This was actually a book that I co-authored. Thank you, Shazadi. And you actually feature in it. There we go.
It's a great book. Yeah.
Yeah, it's not a medical book. It's not an advice book. It's basically an experience sharing book, because I suppose when I did come out of my,
Advert now.
yeah, absolutely. When I came out of my head in the sand stage and thought, this is just bloody ridiculous, I've got to grow up. And I did start thinking more about my menopause and being able to talk about it. And one of the reasons I think that I didn't, apart from all the other nonsense that was going on in my head, is that I didn't feel that my menopause was dramatic enough. You know, because most of the stories that we'd heard at that point were of people, and there are a lot of people whose lives are really turned upside down. And I felt mine was just a bit meh. And so the reason that we did that book was it's 42 different women who are just giving their experience of the menopause. And I kind of look at it as you've got the menopause and you've got your menopause. And you can only really deal with your menopause, can't you? And it's unique to you. But it is really nice to look through a book, just chapter by chapter, and say, oh, that's interesting. That I recognize that, but I didn't put it into that box. Or my goodness, that person has dealt with this in a completely different way. So it's basically an experience sharing book, just to sort of give people a sense of the different kind of experiences that they can have. Right, I'm scrolling down here. I'm going to give you just another minute or so to answer that poll, if you would.
I was just going to say, though, that sometimes some women who have sailed through then come round to HRT because they've got a family history of osteoporosis for their bones and their bone health. And from that perspective, HRT can help from your bone mineral density. So sometimes women may come to it at a later point because they've got a family history, or that they've had a bone scan, they've had a fracture, and they found that that their bones are weaker.
Okay, gosh, we haven't even spoken much about osteoporosis. We should have. Actually, Michelle, who's moderating this, thank you, Michelle, has found that question. I was on the combined pill, so I couldn't take HRT. I rang the GP for advice, was told by the GP the only option is to stop having sex if I wanted to take HRT. He then prescribed me SSRIs, which I had an allergic reaction to, asked to see a female GP, and now have the correct answers. Always seek a second opinion. Yeah, stop having sex doesn't really seem to me very...
Well, he didn't even say condoms. I can't believe he just said stop having sex.
Yeah, I know. I'm just waiting for our poll results to come in. I'm not sure if they are or not. Let me have a wee check. I'm getting to grips with this.
I was just going to say the other thing is you don't have to have a blood test. Remember that. If you're over the age of 45 and you've got symptoms, you don't have to have a blood test. Right. But a time that it might be useful is if you are somebody who is on the Mirena coil or a progesterone-only contraception where you don't have periods regularly.
Well, that's interesting, actually, because one of the earlier questions that I had was regarding home menopause testing kits.
Oh, yes.
Are they accurate? Are they worth it?
So what they measure is your FSH, your follicle stimulating hormone. And if your follicle stimulating hormone is above the age of 25, that indicates that you're, menopausal or in menopause. But it doesn't really, but if it comes back lower than that, it doesn't mean to say you're not as well. So because, it's more about the symptoms rather than the numbers. And so it's a tricky one to know, but sometimes in perimenopause, we need to have a few readings. So a one-off is not going to be okay, usually not enough. And just because it's normal doesn't mean to say you can't seek help and treatment if you've got symptoms. But so I would say sometimes it throws open more questions, and it's better just to go and have a discussion. But if it's something that you can then take, if you find that it might be helpful to take to your GP in your 10-minute consultation, it might be helpful, to have it. But I'm going to say, don't go by the numbers. It's not just the numbers. You are a person, you do have symptoms, so it's not just about the numbers.
Okay, good. We do have the results are in. Would you feel comfortable speaking with your line manager about your menopause symptoms? Very encouragingly, 78% people say that they would. So that really is great news. Obviously, 22% say no, but that is very, very encouraging, I have to say. While I'm at it, before we finish, I'm going to throw you another poll question. I was going to say there's only one answer to this, I don't know, but have you found this useful? Just quickly, because again, it's really good to get feedback. Do you feel more informed about the menopause in the workplace from watching this webinar? Again, it's a simple yes or no. Feel free to say no, because you know what, we can always do it better next time. We're not so blooming proud, but it would be really good to get an idea of whether or not you have found this useful. I'm just looking when I'm letting people respond to that, some of the responses to whether you feel comfortable speaking to your line manager or what suggestions. I struggle because I have a male line manager and I feel embarrassed. I said no because mine's a man, even put it in my supervision and he just dismissed it. We have a job to do, don't we, in bringing men into this conversation, because not to make excuses for the guy, but he's probably embarrassed too.
I mean, the studies have shown that sort of older men, because maybe their wives, their partners have gone through it, are more sympathetic on the whole. But yeah, I think it's an uncomfortable conversation for them, and there's little information out there for them as well. So I think we do need to do more to help them as well.
Yeah, funny you say that. This text in, my manager, not text message, my manager is a man, but his wife is the same age as me, so I would be happy to talk to him as he's a good bloke and will experience at home what I'm talking about. Well, that's really nice to know as well. And we have the results in, Shazati. Do you feel more informed about the menopause in the workplace from watching this webinar? Dun, dun, dun. I'm really, really happy to say 100% of people say that they did. I'm so pleased about that, because you know what, I was really nervous about this today. I think it is close to our hearts, isn't it, all of us, and you really do want to make a difference in a positive way, and conversations do make a difference. They do. And Shazad, I just think you are so good at imparting really good level-headed advice. I mean, I learn from it every time we speak together, so there you go, I'm doing that to you.
Thank you. No, I wanted to say that, you know, one of the things about this journey is, you know, by getting this information, you know, we have, it's not doom and gloom, you know, I think it's just about sort of, you know, understanding it and more, understanding what's going on in your body. You're not going crazy. That's what I'm going to say. You're not going crazy.
Yeah. So people asking, how do we share this session with others? It has been recorded, and Emma Marshall is right on top of this and will be putting out a link to everyone, presumably, who's been watching this, but I would imagine we're widely. I think actually I should bring her on. Emma doesn't want to come on, but I'm going to bring her on anyway. Emma, can we magically bring Emma? Hi, Emma.
Hi.
Hi. Are you happy, Emma?
It was a super session. It really was. I've learned loads. I've got notes and notes here, and not only from you two, who, you know, I knew you'd be fabulous, but to everybody in the chat as well. You know, I've learned so much from you guys as well. And I think the big thing that I want to share, because not clinical, not medical at all, but you know, you're definitely not alone. You are part of this community, and you know, we've got loads of work to do, but we've got a really committed team behind us to take it forward, and it isn't going to get worse, let's put it that way.
Yeah. So will people will be able to either watch this again or to refer it to friends and colleagues?
Yeah, so everybody that booked on, even if you weren't able to join, will get a link, and I will share with you where it's located. You'll be able to click on, you'll be able to rewatch, you'll be able to forward it to your friends, your husbands, your partners, because they might want to know. You might want to share it with your bosses as well. But yeah, hopefully that helps.
Good. And lots of people saying they'd like another webinar, maybe focusing on some of the things that we haven't had the time to discuss. It's difficult because there is just so much ground to cover, isn't there? But that's... Well,
tell us what. Put it in the chat. A webinar on what? And we'll make it happen, I'm sure.
Yeah, fantastic. Well, listen, thank you very much, Emma, for inviting us. Again, I always find it so fascinating listening to Shazadi. She's so well informed in this and puts it across in such an accessible way. But like you, I've learned so much from this chat. It's just been, and I'm sorry if my eyes have been all over the place, folks, because I'm just constantly scrolling through this, and it's just wonderful to see everybody being so generous with their own personal experience. And to be honest, I feel a bit embarrassed in the past that I haven't been able to do that, and I hope that I am now able to do it a lot more. But I think when I see people sharing their own personal experience, it's kind of like a gift to other women. That's a bit un-Scottish of me, isn't it? I better go before I start getting emotional. It's terrible. I've got to take the dog and walk. So thanks, Emma, for inviting us. Thanks, Shazadi. And as I say, I'm really so thrilled that you found this useful, and I wish you all the very best on your continued journey. I'll let you get on with your afternoons now. Thanks.
Bye, everyone.
Bye,
Thank you.
Bye.
Bye, everybody.
Bye.